Welcome to Clinical Minute. Maria is a 35-year-old woman. She has been pregnant 3 times. She has 2 children and had an abortion 3 years ago. Maria is a single parent who works full-time and is highly motivated to prevent pregnancy for the next few years. Over the past year, Maria has not been having sex regularly and hasn't been using a consistent contraceptive method, but she recently began a relationship with David and is interested in starting a new method. Maria thinks that she is finished having children, but she's not 100% certain. Maria and David had unprotected sex 48 hours ago, and Maria is very worried about becoming pregnant. You review Maria's medical record. Maria began menstruating at age 13 and has regular periods that are quite heavy, with occasionally painful cramping. Her last menstrual period began 6 days ago. Maria has no concerning medical history, medication use, or allergies. She occasionally uses tobacco and alcohol and does not use recreational drugs. Maria weighs 145 pounds. How would you begin her EC consult? Maria has clearly communicated that preventing pregnancy is a top priority. Although she is at relatively low risk of pregnancy from the active intercourse that just took place since she is on day 6 of her cycle, she wants to take EC to be as sure as possible. She also wants to start a new ongoing contraceptive method as soon as she can, so she doesn't have to worry about pregnancy for the next few years. You talk with Maria about the overall effectiveness of the different EC methods, whether her weight might impact the effectiveness of her EC method, and which ongoing method she is interested in using. When Maria thinks about which ongoing method she will use, talk with her about whether she prefers a method that she can get one time and forget about, like an IUD, or whether she prefers a method that she uses every day or every week, like the pill or the ring. You will also talk with her about her preferences about monthly bleeding and explain that some methods can make her periods heavier, like the copper IUD, while others might reduce or eliminate her periods, like a levonorgestrel intrauterine system such as Mirena, Skyla, or Liletta. You explain to Maria that there are 3 primary options for emergency contraception. The copper IUD is by far the most effective, followed by Ulipristal Acetate EC pills, and finally, levonorgestrel EC pills. You show Maria this graphic, which describes the number of pregnancies that would be expected among 1,000 women who have had an episode of unprotected sexual intercourse. It's important to note that most women will not get pregnant after one act of unprotected sex, but of course each woman's risk depends on many factors, including where she is in her cycle. You have found that this graphic can be helpful for communicating with patients about the relative effectiveness of the different EC options. You explain that the copper IUD is the most effective method for EC, and is shown here in light blue. If 1,000 women who had unprotected sex used the copper IUD, 1 or 0 would become pregnant. On the next row, in light purple, is the number of women out of 1,000 who would get pregnant after taking Ulipristal Acetate, or UPA. Among women using levonorgestrel, or LNG-EC, about 10 women out of 1,000 would get pregnant. And shown in yellow, about 20 women using the USP method would get pregnant. The USP method is using regular oral contraceptive pills in different combinations as emergency contraception. You explain to Maria that this method is not widely recommended because it is less effective than the other methods and has more side effects, but it is still used in situations where access to the other methods is restricted. Finally, in green, we see that among women using no method at all, about 80 would get pregnant. The copper IUD is by far the most effective method of emergency contraception. A review of 42 studies of the copper IUD as EC showed only 6 pregnancies among nearly 7,000 insertions after unprotected sex. If left in place, the copper IUD offers at least 12 years of excellent ongoing contraceptive coverage, and possibly more. The copper IUD needs to be placed by a trained provider. Most emergency contraception guidelines recommend placing the IUD within 5 days of unprotected sex, or within 5 days of ovulation if the date of ovulation is known. This recommendation is intended to reduce the possibility that the IUD would be inserted into a woman who is already pregnant, or that it could interfere with implantation of a fertilized egg. You discuss the option of the copper IUD with Maria. Although she is very interested in a long-acting method, her periods are already very heavy, and she is concerned about having potentially heavier menses with the copper IUD. You move on and consider the EC pill options with her. You know that some patients are not interested in the copper IUD. For these patients, the next most effective option for EC is Ulipristal Acetate pills, sold in the United States as ELA. Ulipristal Acetate, or UPA, is available by prescription only. You recall from experiences with other patients that it isn't yet routinely stocked in all pharmacies, so you generally call the pharmacy before prescribing it to make sure that it's there when the patient needs it. You know that the label says that it is effective for 5 days, but that it should be taken as soon as possible. Ulipristal Acetate, UPA, works by preventing ovulation, and because most women probably don't know exactly where they are in their cycle, taking it right away increases the chance that a woman will be able to take it before the process of ovulation begins. Levonorgestrel, or LNG, emergency contraception pills are available over the counter without any restrictions. You and Maria talk about the fact that until fairly recently, there were age restrictions on the non-prescription sale of LNG emergency contraception, and the frequent regulatory changes have resulted in a lot of confusion. But women and men of any age should be able to buy LNG EC off the shelf in a retail pharmacy without showing identification. You know that even though LNG EC pills are generally the easiest EC method to access, they are not the most effective method. You explain to Maria that UPA and LNG both work by delaying or inhibiting ovulation, but UPA is more effective than LNG. This is because LNG EC doesn't work after the luteinizing hormone, or LH, surge has started. UPA works even after the LH surge has started, as long as it's taken before the LH peak, so it works closer to the time ovulation would occur. In one study in women treated before the LH surge began, UPA prevented follicular rupture in all women. Among those treated after onset of the LH surge, but before the LH peak, it worked in nearly 80% of women. Among women treated after the LH peak, UPA prevented ovulation in only 8% of women. Another issue that you routinely consider when counseling a patient about EC is her weight. You've read that there is some evidence that EC pills may be less effective for women at higher body mass index or weight. LNG may be ineffective for women weighing 176 pounds or more, and UPA may be ineffective for women who weigh 194 pounds or more. There is no loss of effectiveness for the copper IUD, regardless of the woman's weight. The IUD and UPA are the most effective methods for all women, no matter what they weigh. But if options are limited, you understand that women shouldn't be denied EC pills. If LNG is the only method available, you try to ensure that your patient has the option of using it, regardless of her weight. Since Maria is not interested in the copper IUD, you talk with Maria about the EC pill options. You know that Maria weighs 145 pounds, so it's unlikely that her weight would impact the efficacy of either LNG or UPA. Maria is open to either pill option and would prefer the most effective option that she can get. Now that you know Maria is going to use one of the pills for EC, next you talk with her about which ongoing method she would like to use. It's important to think about EC pills and ongoing contraception together, because there may be interactions between UPA-EC and hormonal contraceptives. Because UPA is an anti-progestin, there is a theoretical concern that following it up quickly with a progestin could counteract the effect of the UPA-EC. You recall the recent study you just read, which found that when women started a particular type of progestin-only oral contraceptive pill, containing desogestrel, the day after taking UPA, ovulation occurred within 5 days in 45% of cycles. It's not certain whether these findings would apply to other types of hormonal contraceptives, such as the levonorgestrel intrauterine system or the implant. Some new guidelines recommend waiting 5 days after taking UPA to start a new hormonal contraceptive method. You know that there are many unanswered questions about how broadly these findings apply, and that for each patient, you need to balance the loss of efficacy of the UPA with the potential lost opportunity for a woman to get started on a new method right away. Until new studies are done, you've decided to proceed with caution and avoid following UPA immediately with any progestin-containing contraceptive. As you counsel Maria on her options, you talk about the EC method and the ongoing method in the same conversation because you know one choice will affect the other. After you determine which ongoing method Maria wants, you assess how feasible it is for her to return for a follow-up contraceptive visit in a few days. Like with all EC patients, you remind Maria that she should use condoms or abstain until her new method is effective, 7 days for women using LNG EC and 14 days for women using UPA. For women who need EC because they missed too many of their oral contraceptive pills, you know that you do not recommend UPA, as there can be a decrease in effectiveness due to the interaction of the antiprogestin and the progestin. In this case, you offer LNG and recommend that she resume taking her pills or start a new pack if she is on the last week of her pills. You also advise the woman to use backup, such as a barrier method or abstinence, for 7 days. For women who want to start a new oral contraceptive, the patch or the ring, offer UPA. If the pill she's starting contains placebo pills, have her start with those immediately. If the pill she's starting doesn't contain placebos, or if she wants to start the patch or the ring, provide the new method and tell her to start the pills 5 days after she had sex. Suggest she put a reminder in her calendar on her phone or write down for her on a piece of paper the date and day of the week she should start her pills. Advise the woman to abstain or use condoms for 14 days. After talking with Maria, you understand she is not interested in using a method that she needs to actively manage, like the pill or the ring. She wants something that will provide protection for several years without her having to think about it. You move on to the options for long-acting contraception after EC. If Maria is interested in starting a long-acting method, you should first be reasonably certain that she isn't pregnant, using guidelines from the CDC's selected practice recommendations for contraceptive use. You can be reasonably certain that a woman isn't pregnant if she has no signs or symptoms of pregnancy and also meets one of these other criteria. She's 7 or fewer days from the start of normal menses, hasn't had sexual intercourse since the start of last normal menses, she's been correctly and consistently using a reliable method of contraception, she's within days after spontaneous or induced abortion, she's within 4 weeks postpartum, or she is fully or nearly fully breastfeeding, amenorrheic, and less than 6 months postpartum. From the history you took at the beginning of Maria's visit, you understand that her last normal menses began 6 days ago, so you can be reasonably certain that she isn't pregnant and can move on to working with Maria to determine which long-acting method is right for her and which EC method she should use. For a woman who wants to start a long-acting hormonal method that needs to be provided by a healthcare provider, consider how likely it is that the woman will be able to return for a follow-up visit. If she is likely to return for follow-up, give her UPA and schedule an appointment to get her ongoing method no sooner than 5 days after she had unprotected sex. It's particularly important to rule out pregnancy before providing a levonorgestrel intrauterine system, such as Mirena, Liletta, or Skyla, due to risk of harm to an existing pregnancy if the woman is already pregnant. Patients using any of these methods after UPA should use condoms for 14 days. You know from experience that some patients may have difficulty returning for a follow-up visit to start a new method. If Maria is not likely to return for follow-up, give her LNG EC and provide the new method right away. Again, if she wants to use a levonorgestrel intrauterine system, it's particularly important to follow the Selected Practice Recommendations guidelines for ruling out pregnancy. She should use condoms or abstain for 7 days after the visit. You talk with Maria about whether it's likely that she will be able to come back for a follow-up visit. Maria had unprotected sex 3 days ago, so counting 5 days forward from there, if she took UPA today, she would be able to get her ongoing method in 2 days. Maria tells you that her life is hectic, balancing work and her family schedule, and she doesn't think that she will be able to come back to your office anytime soon for a follow-up contraceptive visit. You and Maria decide it would be best for her to take LNG EC and get her ongoing method today. You talk about her options for ongoing contraception, and she is interested in the 5-year levonorgestrel intrauterine system, Mirena. Maria has told you that she is not interested in the copper IUD because she already has heavy periods and is concerned that a copper IUD might make them even heavier. Because you know that her last period started 6 days ago, you are reasonably certain she is not pregnant. Although Maria is probably at low risk for pregnancy at this time in her cycle, you know that she is very highly motivated to avoid pregnancy and doesn't want to leave anything to chance. You can provide the new method today. Maria is relieved that she was able to receive EC and choose an ongoing contraception that will fit her life.